Well, the final talk of the morning and of this entire symposium is by Dr. Randy Starling. And Dr. Starling, in addition to being a good friend, is an accomplished heart failure and transplant physician. He's the co-chairman of the Department of Cardiology at the Cleveland Clinic and an established investigator in a variety of trials that have shaped the way we practice heart failure and transplantation. And we've asked Dr. Starling to comment on this patient population who's at the end stages of their disease and what our treatment options are for these individuals. Randy, thanks very much for coming to Asheville.
Thanks, Joe. It's a great pleasure to be here, and it's been a wonderful morning. I've enjoyed all the presentations. So when I thought about this title, Novel Heart Failure Treatments, what do we do when standard treatments fail? There's a number of ways I could have gone with this, and feel free in the question period to ask anything you like. I've addressed this topic before, sometimes with a specific agenda, such as the cardiorenal patient, certainly end-stage heart failure. What are the options? What about somebody that got CRT but it's not working, so-called ineffective CRT or a non-responder? Patients that are intolerant of medications, patients that are on medicines but they're not doing well. So there's a lot of ways I could have gone here. The easy way out for me is to talk about what I deal with every day, which is advanced therapies. So I put this in the context of what are the goals, and the goals are survival, quality of life, which is typically measured as can the patient walk to the store, to the mailbox, as Dr. Rogers likes to tell me when we're working on a clinical trial, reduce readmissions, which you've heard about today. I do think in the context of reverse remodeling, there are plenty of patients that I have seen that were sent to me for a transplant that got better. There was something that was there that could be addressed. And certainly prevention, which we don't talk about a whole lot, but in that stage A category, it is something we should pay a lot of attention to. It's very important. So let me go right into so-called stage D, refractory heart failure that requires specialized interventions. And this slide is right from the American Heart Association, American College of Cardiology guidelines. So these are the patients that have marked symptoms at rest despite maximal medical and device therapy. You know who they are. They're in and out of the hospital. And the goals as far as treatment of these patients are to do everything that you've already heard about today. The so-called medications and treatments for levels B and C heart failure. But the list of options is very short, as you can see here. Compassionate end-of-life care or hospice, which is something that the four of us don't like to think about a lot, but it's actually a very important part of it should be a very important of our practice. Where we spend a lot of our time is the extraordinary measures, heart transplant, chronic inotropes, permanent devices, and experimental, of which there's really not much there. So this is a graph from a paper that was published from our clinic in Circulation Heart Failure last year. So this was a retrospective look at 110 patients that we discharged that our team of heart failure specialists felt these are refractory patients. The only way we can get them home is on an inotrope. Most of them were in the they were all in the intensive care unit. They had a pulmonary artery catheter in place at one point in time, and they were deemed to be inotrope dependent. And this is similar to what other studies have reported, and essentially it showed that at 6 months, about half the patients were dead. Now, the survival curve continues because some of these patients actually did get some advanced therapy, so they're alive, but in other series it's shown at 12 months that about 95% of the patients are dead. And interestingly enough, the ICD did not make a difference, which is why you'll hear electrophysiologists, and maybe this came up yesterday, and the really advanced patient, class 4 patient, it's typically not indicated to put a device in. So this is what you get with chronic inotropic therapy. And in fact, in the discussion of this paper, we were encouraged by the editor to add this statement, which we did. And it said, if a patient is not a candidate for LVAD or transplant, they should be referred to hospice. So this is a figure from a paper published from the European, they have a work group in the European Society of Cardiology called the Work Group for Advanced Heart Failure. And the key point on here is the top line is patients with cancer that tend to do okay, have a decent performance status, and then they precipitously fall off the curve, so to speak, and they die. If you look at the middle line, this is heart failure patients. This represents organ failure patients, which is characterized by these peaks and valleys. We all get patients that come in, they're class 4, sometimes we're effective, we tune them up, they go home, they think everything's okay, only to have another exacerbation and a slow downhill trajectory. And actually, in the European literature, they are advocating that we as heart failure specialists should be talking to patients about end-of-life, hospice, palliative care right up front when we tell them that you have a chronic disease, that no matter what happens, you get a transplant, you get an LVAD, you go on chronic inotropes, you're going to die of this disease, and it's a matter of when and where it happens. And that's not something that we've been real effective at the Cleveland Clinic. Now, I thought I might be able to add a little bit to my credibility since I'm from Cleveland. That's in the north, but I'm actually from, or my family is from Eden, North Carolina, and my cousin just sent me this sign that she had made for the family cemetery, and I unfortunately have relatives buried there that have died of heart failure. So this is an extremely common disease. As you've heard, it's the number one DRG. It's the number one cause for admission. The mortality rate is extremely, extremely high. And I just sat with a patient Thursday afternoon, and 60 years old, dying of heart failure, and I said to him, how long do you want to live? Because I have options. And he said, I want to live as long as I can. But then he said, but I don't want one of those LVADs, period. So it's a very, very tough disease. So let's look at what some of the options are. But first, I just want to kind of outline a little bit of epidemiology. And this is a figure that we recently put together based upon the U.S. population in 2010. So what we're looking at is a pool of patients that if we take the population in the U.S. greater than age 20, and if we estimate, and this is from the American Heart Association, 2.6% of the population has heart failure, that's 6.24 million. About half of them will have systolic heart failure, so that's 3 million there. And then this is based on some population estimates both in Europe but also from Olmsted County and Minnesota. We really don't know what percentage of patients have this very advanced stage D failure, but the ranges in the literature are from as low as 0.5% to as high as 5 to 6%. And then there's this so-called stage C heart failure, which are symptomatic patients, but you're going to hear heart failure doctors talking more about the 3Bs and the advanced stage C. These are the people that have been class 4 sometime within the last 6 months, but they've rallied, so to speak, so they're still on that up and down trajectory. So the population estimates, and this would really be the number of patients that need a heart transplant or a mechanical support device, you can see and these we consider to be conservative estimates, a low of about 109,000 to a high of about 280,000. So just keep those numbers in mind, between 100 and 300,000 patients in the U.S. alone. So here's the treatment options that we have: heart transplantation, left ventricular assist device, and certainly there are clinical trials that are out there. So I want to just briefly review cardiac transplantation. Been around a long time, really was done first in Richmond at Medical College of Virginia by Richard Lauer, and a lot of the progress from that time forward took place at Stanford and then in Tucson by Jack Copeland, who was the surgeon that trained with Dr. Shumway. But back in 1975, when this paper was published in Circulation, they were touting that their survival rates were 48% at 1 year and 25% at 3 years. Those are the kind of numbers that we saw with LVADS 10 years ago, and our community really wouldn't accept those numbers. But 25 years ago, this was as good as it got. So where are we today? Survival is very, very good, and I will show you that. The incidence of rejection is now very low. In most programs, it's probably 10 to 20% of patients now have an episode of rejection, and very few of them have an episode of rejection that requires hospitalization and is really a significant problem. What we're finding is a really big problem that we're facing is that these patients are treated with cyclosporin, tacrolimus, calcineurin inhibitors. The kidneys are really taking a hit. And about 5%, 3 to 5% of patients by 5 years after a transplant will have a GFR under 30 and be in trouble. So this is really an issue. Coronary artery disease, or we typically refer to it as coronary artery vasculopathy, is a problem that hasn't gone away. And what I usually tell a patient is, you're 30 and we'll give you a heart from a 20-year-old, and you could have coronary disease a year later. That's a reality. Fortunately, it doesn't happen that common, but it is an Achilles heel that we still face. And as I'm going to show you, there hasn't been any growth. So this is all of these slides. You can find any of them publicly available on the internet. This is from the International Society of Heart and Lung Transplantation. And the green is North America. And what it shows is for the last 10 years, between Duke and Cleveland Clinic and WashU and every place in the U.S. and Canada, we're only doing about 2,100, 2,200 heart transplants. It hasn't changed. And remember what I showed you before, there's between 100 and 300,000 patients that potentially need treatment from us. So we have a big problem from that perspective. And the population is also aging. And what this shows, the yellow and the purple lines are the most recent eras that have been looked at. The green line is from 1982 to 1991. So in transplantation, the biggest growing segment is actually in the group between 60 and 69. So we have an aging population, a higher prevalence of heart failure, and a fixed supply of hearts. So it creates difficulty for us. The other issue that I think that's very important to realize with cardiac transplantation is that you'll hear transplant specialists say 90% 1-year survival rate. True. We all have, that's about what we get. But the sobering news is that the conditional half-life for somebody that gets a heart transplant is about 10 to 12 years. So half the patients make it to 10 to 12 years. The rest are already dead by that point. And if you're lucky in your program, 20 to 30% of your patients are alive 20 years later. So nowadays, we have to look at a patient and strategize, how can we keep you alive the rest of your life? Will one heart transplant do it? Not if you're 35 or 40. If you're 50 or 60 or 65, a transplant's probably going to work out just great. So we have to really look at the continuum, and this is the perspective from transplantation. The other variable that is important is that there is a price you pay with age, and this is international data, and it does show with the population over age 70, that's the blue line down here, the survival drops off. That's not surprising when you get out here to 8 to 10 years if you just look at life table analyses, but this also creates a difficulty when making decisions about how you're going to allocate hearts. Some programs in the U.S., somewhat arbitrarily perhaps, make the decision that they have an age cutoff, whether it's 65 or 70 or what have you. Most programs have an age limit. Many programs, such as ours in Cleveland, we don't post or advertise a specific age limit, but we make a strong educational point to our patients and referring physicians that age is a risk factor. And we look at all the risk factors when we decide what we think is the best therapy for somebody that gets to this point. This is just to show that over the last 20 years, the mix of patients that comes to transplantation is about the same. The bulk, 50%, are idiopathic cardiomyopathy. Perhaps the percentage with coronary disease has fallen a little bit, and then there's a smattering of congenital. And this retransplantation is becoming a bigger and bigger problem for all of us in the field as our programs have matured. And bear in mind, most of the big heart transplant programs have only been around since 1985. So we're just now starting to see the next wave of patients that's coming to us that need something else because their first heart is failing. They've got coronary disease, they've had infarcts, they've got stents in, they need additional therapies. So what about quality metrics? This is something that is on everybody's front page now as far as readmission rates, inpatient mortality, HCAHPS, leapfrog, all of these quality measures. Well, transplantation has been subject to this almost from the beginning. And I just want to point out to you all that you can look for yourself or direct a patient to this website, ustransplant.org. You can look up any transplant program in the U.S., and you can drill down, and it's updated every 6 months. So the key metrics that you can find on this website are what the one-year survival rate is, what the expected is based on the severity or the case mix that the program is doing. You can see what their waiting time is, and that is compared to the national average. You can see what percentage of the patients die on the waiting list, how many patients are on the waiting list, how many transplants they did the year before. And the newest metric that is on the list now is how many patients are on devices, because we're going to talk about devices today too. So there's a lot of variability from center to center as far as how many patients get put on a left ventricular assist device or an LVAD before they get a transplant. And I don't know if Dr. Rogers is able to explain this. I'm somewhat puzzled by it, but this is a program in California that supports 14% of their patients. This is a program in New York that supports 44% of their patients. Their survival rates are about the same, but their waiting times are different. So it may be related to the fact that, one in a dense metropolitan area, they just can't get hearts, so they have to have more patients that get supported by device. But there's also, the climate is changing rapidly as far as what the thresholds now are to put left ventricular assist devices in.
Randy, can you go back just one slide? I'd like you to comment on one of these lines, and that's the waiting time. We constantly hear in the press and at meetings that the length of time that people are waiting is getting longer and longer, and that's partly why we're using more assist devices. But when you look at this graph, it looks like geez, that the median waiting time is somewhere between 1.5 and 4.5 months. Doesn't seem all that long. I mean, can you sort of comment on that, because it seems to be discrepant from the message that patients are getting?
Yeah, I think that the numbers are a little bit deceiving. In cardiac transplantation, unlike renal transplantation, we've probably done a better job of managing the waiting list in that there's probably in total 3,000 to 4,000 people on the heart transplant waiting list. And this is median waiting time. So the problem that we have is that we know that if a patient is a blood group A or a blood group O and they weigh over 200 pounds, that's where the high demand is. And those patients do typically wait the longest. Whereas patients that are smaller, 120 pounds or less, blood group A, blood group AB, whatever, they tend to have shorter waiting times. And the other thing about the waiting time that doesn't show up on this has to do with the risk that the program is willing to take. So, for example, in Cleveland, we have a jet that's available 24/7. We fly to Florida. We'll go take a heart in Georgia or Texas that other programs have turned down. Maybe the donor's 55 or 60 years of age. So that's the other variable that goes into it, which some programs are more conservative than others, so they're going to have longer waiting times. That metric is being looked at, though, by the United Network of Organ Sharing. They're going to start to look at a metric as far as how often a program turns down hearts that wind up being used by another program. So I'm not going to go through this in detail, but I just want to point out to you that, again, this article is posted on the internet. It's from the Journal of Heart and Lung Transplantation, and these are evidence-based guidelines for selecting patients for transplantation. So the main issues that we deal with are that the patient truly is functionally impaired, and we typically do that with a metabolic stress test and measure peak oxygen consumption. We pay very careful attention to the patient's pulmonary artery pressures and whether they have elevated pulmonary vascular resistance, which is a very important variable in transplantation. We carefully assess them for all their comorbidities, tobacco and substance abuse. And the metric really is that every program has a multidisciplinary committee that reviews the case and makes a decision that they really think from a risk-benefit standpoint that it's going to work out for the patient. But this is the other sobering statistic that's been going on in the U.S. So patients are listed based on severity of illness. So a status 1A patient is somebody that's in the intensive care unit on an inotrope, maybe has a balloon pump and a ventilator, and the allocation of organs in the U.S. is designed to preferentially get the organs to those patients that are really, really sick. And the allocation scheme changed in 2006, and it has effectively accomplished what it wanted to do. More organs are going to the very ill patients. The waiting list mortality has gone down. But what's happened is this group, the status 2, which are the ambulatory patients, functionally impaired, they're not in the hospital, they are waiting a long time, and they are now representing about 10% of the transplants that are done in the U.S. So these are the walking wounded that come and see us month after month. They don't feel good, but they're not sick enough to be in the hospital. So this is a problem for us. And from an evidence standpoint, these patients, and they're represented by this yellow line here, they do have pretty good survival rates. They're maintained with defibrillators. They're maintained on evidence-based medicine. It's not like they're, looking at a 50% 6-month mortality rate. They're not on inotropes, but they are functionally impaired. So this is a target area of patients that we have to try to figure out how to help. I mentioned that rejection is uncommon, but if patients do have rejection, they pay a price for it, and survival is not as good. The other thing about transplantation that's important for everyone to realize is that there are a number of comorbidities that are associated with it. I already mentioned the renal dysfunction, and this slide shows at 1 year, at 5 years, and at 10 years, and you can see that at 5 years, 20% of the patients have an abnormal creatinine, 7%, 7.5 is greater than 2.5, and there's another paper which I'm not showing, but it did show that about 5% at 5 years are either been transplanted or on dialysis or have a GFR less than 30. Hypertension affects almost every patient. Part of that is driven by the immunosuppressive medication, the calcineurin inhibitor. Hyperlipidemia is very common. About 20 to 30% of patients will develop de novo diabetes, and the coronary artery disease, as I mentioned, is a common problem. So what can I tell you about transplant vasculopathy? This is an angiogram of a patient that's had a heart transplant. Looks pretty good. But if you look at the intravascular ultrasound, here's the lumen that you see right here, but this is a big area of disease. And intravascular ultrasound is commonly used to study these patients, and it is used commonly in the clinical trials that we do. And we look at this coronary artery vasculopathy and the change in the intima at different intervals from a prognostic standpoint. Patients clearly don't survive and do as well that have coronary vasculopathy. We've looked at a number of different drugs, including drugs like everolimus that are in the coated stents and sirolimus, but to date there's not any data that has shown a tremendous impact on survival. This is one paper that was published from our group in collaboration with UCLA. It hasn't been widely adopted. The FDA has not accepted intravascular ultrasound as a so-called surrogate endpoint. But basically what we showed in this analysis, and it was replicated by UCLA, is if a patient develops a 0.5 millimeter or greater of thickening of a coronary artery in the first year after transplantation, it's predictive of developing angiographic disease, and you can see down the road, 8 to 10 years, these curves start to split. So again, a very important problem and a major limitation that we face in transplantation. These patients are labor intensive. They're getting heart biopsies, catheterizations, a variety of testing. The new kid on the block, so to speak, is so-called gene expression profiling. There was a paper in the New England Journal this year that proposed that we could follow patients with a blood test that looks at upregulation of a gene panel rather than doing heart biopsies as part of surveillance. New, under discussion. I don't know if Duke has embraced this, but it's somewhat contentious, I would say, in the community. So I've reviewed for you the limitations of cardiac transplantation. There are many reasons that patients are seen that they're not considered good candidates. And so what else do we have to offer? And that's really mechanical devices. And we think of mechanical devices in a number of categories: bridge to transplant, bridge to decision or candidacy, chronic or destination, and acute or short-term support. So just for simplicity, I'm going to divide the devices into 3 broad categories. This is a so-called Pulsatile pump. These are the first generation pumps. They're larger. They weigh multiple pounds. They make noise. They have a stroke volume of about 80 cc's on every beat. This pump gets implanted into the abdomen. Then there's the newer pumps that weigh less than a pound. They're so-called axial flow, meaning they're going 8 to 10,000 RPMs. They're quiet, and I'll show you some clinical trials. And then there's the centrifugal flow pump, where the blood comes in. There's a rotor that's spinning around, and then the blood comes out. These rotate at about 2 to 3,000 RPMs. So if you turn the clock back to 1998, I didn't dye my hair back then. I've just gotten gray hair. This is a guy who happens to be a physician, And this is what we had. He was pushing this thing around that weighed about 80 pounds. This was the driver. He's got a pump here in his belly, and he was hanging out in the hospital waiting to get a heart transplant, which he did, and he's still alive. The guy's over 80 years old with his heart transplant. Now, where are we in...
You got it.
30 years into his relentless battle with heart disease, former Vice President Dick Cheney is recovering from his most serious medical challenge yet. Doctors for the...
Okay, I guess we've got some technical issues.
You got it.
30 years into his relentless battle with heart disease, former Vice President Dick Cheney is recovering from his most serious medical challenge yet. Doctors for the...
So the video's not running, but I'm sure everybody in the room knows that Vice President Dick Cheney was announced about 2 weeks ago. He's got an LVAD. He's 69 years old. So Dr. Rogers said to me last night, what's been the Cheney reaction? So this was the Cheney reaction, but it's not playing. So Dick Cheney, we think, has a new axial flow pump. So I'm going to show you what the results are with that. So these pumps have only been approved for a couple of years. And the first approval was for a pump to be used in somebody that was waiting for a heart transplant. And what we saw was that these pumps work very, very well. 89% of the patients were alive after a month of support, and close to 80% after 6 months of support. So physicians were very confident that they had a tool that they could use for sick patients. And in fact, after this pump was approved, the FDA required a post-market evaluation on the first 170 patients. And what it showed was 96% of the patients were alive after a month of support and 91% at 6 months. So we have a very good tool now that we can use for patients that are failing on medication that are waiting to get a transplant. And there's a registry of data. This is also publicly available information. It's called Intermax, and we all have to report data into this. We're required to, or we don't get reimbursed by Medicare. And basically what this is showing is the survival rate in patients that have these pumps put in, which is 74% at 12 months. Not as good as a transplant, but getting better and better and better. The other thing that we're learning is that if you stratify patients based upon their level of illness when they go to the operating room, so the blue line is critical cardiogenic shock. This is somebody that is on a ventilator, on a balloon pump, their bilirubin's up, their creatinine's up, they are really, really sick. They don't do as well as a patient that is ambulatory, that comes in electively. So the field is starting to move away from operating on those patients in a crisis situation. And there's other tools that are being used by interventional cardiologists and heart failure specialists, percutaneous support devices that we have to, quote, tune the patients up before they go for one of these more durable pumps. So this is actually data that is from Dr. Rogers and his colleagues from a paper that they published in the New England Journal last year and gave a presentation at the American Heart Association. So this is the old pump, which weighs 1,250 grams. This is the new pump that weighs 390 grams. This is the pump that we think Dick Cheney has. This is loud. This is quiet. They both can deliver up to 10 years of flow. The problem with this pump was most patients had to get a new one put in within 2 years. It just didn't hold up. This pump, we think, can last 4 to 5 years without too much problems. And this is data published last November in the New England Journal, now testing the application of this device in patients that aren't transplant candidates that would otherwise stay on a chronic inotrope, go into hospice, basically no option but to die, that elected to have a continuous flow pump put in, and their survival rates in this clinical trial were 68% at a year and 55% at 2 years. And comparing that to the older generation pump that I showed you, a marked improvement at 2 years. And this happened in less than 10 years. So the technology is moving very quickly. And this just reinforces, this is with the latest edition continuous flow pump, and this is historical controls from around 2002 on medical therapy. So 8% versus 58% survival between the mechanical pump and the inotrope at 2 years. And Dr. Rogers actually just published a paper in the Journal of American College of Cardiology, and I was invited to write an editorial. And what they showed in their paper was the improvement in ability to walk of 156 meters. If you compare that to cardiac resynchronization therapy, it was, let's say 39 or plus 39 meters versus 156. So just unbelievable improvements and reduction in what's called the Minnesota Living with Heart Failure score, the Kansas City Cardiomyopathy score. So we've really never seen these types of improvements. And this is showing just what the growth has been over the course of a couple of years. So this is a very rapidly expanding field as far as treatment. And this was published in the Wall Street Journal last December, a heart transplant alternative. And this, I believe, is one of Dr. Rogers' patients that had this HeartMate 2 pump put in at Duke. And where does he live, in Texas, Joe?
This guy lives in South Carolina.
South Carolina. So it was reported in this article that he gets on the airplanes and flies around and is living a pretty good life. And those of us that work in the field, we are seeing a transition in care for heart failure. It's happening right now. And just to close, this is one of my patients. Just to give you a flavor for the case history. So this man came to see us for advanced therapies. His doctor, he was in the hospital 8 or 9 times, but he presented with a history of rectal cancer and a colostomy, and it had been less than 2 years since his diagnosis. So he was really not considered to be a transplant candidate because of his malignancy history. We hospitalized him. We did what the ESCAPE trial said not to do. We put a PA catheter in him. We put him on nitroprusside. We adjusted all of his medicines. And we kept him out of the hospital for about 6 months. But then he just went downhill again. So he actually came back and saw me in December and had that copy of the Wall Street Journal with Dr. Rogers' patient's picture. And he asked me if he could get one of those devices. So and he was ambulatory, not on any inotropes. He had elective surgery like 3 days after the device was FDA approved. It's FDA approved now, actually. 14 days length of stay. Comes to the VAD clinic every couple of weeks. He hasn't been rehospitalized. So that's kind of where things are. Just to be complete, I want to mention that there is a total artificial heart. It's not used very commonly. I believe they have it at Duke. It's at most major centers. If somebody has really severe biventricular failure, we can use this, but it's got this gigantic machine that has to be pushed around. They have come out with a very small driver, and the Mayo Clinic in Scottsdale just discharged their first patient. And people in Europe actually get this in their chest for chronic therapy that aren't going to get a transplant. But we're not there yet in the U.S. And I just want to mention, and we'll be happy to take questions on this collectively, lots of patients come and ask about stem cells. And in my opinion, for the patients that are advanced like I've been talking about, we don't really have anything to offer them in the context of stem cells. The trials that are out there, and we participate in an NIH network, our patients are way too sick. The patients that are getting in these trials are class 2, maybe class 3, They're not really advanced heart failure patients. The average increase in ejection fraction is 4 to 5 ejection fraction points in what's published now. I've had patients that have gone to India, Thailand, and gotten stem cells and come back. Most of them that come back to see me, they come because they're not doing very well. So I don't consider this yet a prime time alternative to the really advanced heart failure in my practice. So we are involved in an evolutionary process of change within advanced heart failure, and those of us in the field are in the midst of trying to figure out what the best thing to do is. There's a patient in this picture that has an LVAD in, and he actually came to the Cleveland Clinic with bad aortic valve disease. He had his aortic valve replaced, but his heart it wouldn't tolerate him getting out of the operating room. So he had a HeartMate axial flow pump put in, and he actually was the king of the Mardi Gras parade in New Orleans at the last Mardi Gras. So that's the fellow in the middle with his 2 sons. So we've made a lot of progress with these mechanical support devices. Thank you.